Welcome to the Gyne Awareness Podcast, real talk to understanding gynecologic conditions and care. The goal of this podcast is to bring you clear, evidence-based medical information by experts in the field of gynecology to help empower you in your health journey. Participants on this podcast are healthcare professionals, specialists and advocates in the field of minimally invasive gynecologic surgery. The views and opinions shared in this podcast are those of the speakers and do not necessarily reflect the official policy of AAGL. This content is provided for general educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Listeners should always seek the guidance of a qualified healthcare provider with any questions about their own health. If you are experiencing a medical emergency, call 911 or your local emergency number immediately.
Welcome to the Gyne Awareness Podcast. My name is Dr. Angela Chaudhari, and I'm a gynecologic surgeon and Vice Chair and Chief of Gynecology at Northwestern Medicine in Chicago, Illinois. I will be your host today for the AAGL Gyne Awareness Podcast, a podcast designed for all of you, our patients, to empower you in your personal health journey. We are bringing you experts in the field to hear the real truth about conditions that impact so many people. Today, we will be discussing all things uterine fibroids, what they are, how they present, and what your treatment options are. And we have an absolutely amazing expert panel today. First, Dr. Jamal Mourad is an Associate Program Director for the Fellowship in Minimally Invasive Gynecologic Surgery and is an Assistant Professor of OBGYN at the Mayo Clinic Alex School of Medicine. He also holds the title of Associate Professor of OBGYN at the University of Arizona College of Medicine, Phoenix, affiliated with Banner University. He's a board-certified fellow of the American Board of OBGYN with a focused practice designation in minimally invasive gynecologic surgery. Next up, Dr. Matthew Siedhoff is a professor of obstetrics and gynecology at Cedars-Sinai Medical Center in Los Angeles, where he has served as vice chair of gynecology. He's a gynecologic surgeon who specializes in advanced laparoscopic and robotic surgery for complex endometriosis, uterine fibroids, and reproductive surgery, as well as an expert in surgical education. He has recently started his own practice in the Los Angeles area. And last but certainly not least, Dr. Arleen Song is a faculty member and fellowship program director in minimally invasive gynecologic surgery in the Department of OBGYN at Duke University. She completed her fellowship training at the University of Michigan and serves as faculty in the MIGS division at Michigan prior to joining Duke. She now takes care of patients across the gynecologic surgery spectrum, including fibroids, endometriosis, and all things abnormal. Welcome to all four of you. I'm so happy you guys are here with us today. So let's get us all started off. We're obviously talking about uterine fibroids. Guys, can we just explain to the audience really what are uterine fibroids?
Well,
Jamal, I'm going to call on you first.
All right. Well, I start my conversation with all my patients and women interested in learning more about uterine fibroids, explain that this is simply a seed. It starts out as a little seed of smooth muscle type cells that don't know when to stop growing. They continue to grow year after year, decade after decade, until things slow down a little bit more later on. I'd like to also emphasize the fact that these are not cancerous tumors. They're tumors, but they're not malignancies. They're benign disease that can sometimes cause symptoms. That's how I start the conversation.
Okay, so wait a second. Even before we start out with what are fibroids, I guess, who are these patients coming to see us? What kind of symptoms are you guys seeing in your office when you start thinking about fibroids being a problem? Arleen, take this one.
Yeah, usually we see fibroid symptoms kind of come in two groups, and I usually categorize them in bleeding symptoms versus maybe bulk symptoms or pain and pressure symptoms. And those symptoms can come from fibroids based on where they are, their location, the number, the size of fibroids. So patients can have different types of fibroids and size of fibroids with much different symptoms than another patient with fibroids. So sometimes patients have no symptoms from fibroids. They can have fibroids for a number of years. And in fact, many women will go through their entire lives with fibroids and not have any intervention with them. But many women will have bleeding or bulk symptoms or pain and pressure from fibroids that really can occur so gradually over their reproductive lives that they actually don't even know that they have fibroids until they are older, and maybe when they're starting to have much more severe symptoms, or maybe attempting fertility or having other goals from a gynecologic standpoint.
Okay, so when we talk, let's start with bleeding, guys. Okay, so when we're talking bleeding, what does that mean for patients? Like, obviously, women bleed every month unless they're on a pill or something like that. When should a woman who thinks she's having abnormal bleeding, when should she go see her doctor? Matthew, what do you think? What are the real symptoms that you see in your patients?
Sure. I think, it's obviously going to differ from person to person, but I think anytime there's a question, check in, because there's a lot of folks who sort of normalize what they're experiencing, think this is normal for me, or, I don't know, I got a little bit older, or something else happened in their life and they sort of attributed that to it. But it really could be a sign that something's going on. To your point, they could have had a fibroid that's been sort of smoldering for a while, and now it's gotten just to the size where maybe it's affecting the lining of the uterus that sheds every month with a period, and that's now why it's starting to manifest with heavier bleeding. Or it's just gotten larger to the point where the whole uterus is enlarged, and that's causing heavier bleeding. It never hurts to check in with your doctor. And a lot of times, as with many things, if you intervene sooner, the intervention's a little simpler. So if the fibroid's a little smaller, it might be a little easier to treat, or you might have more options when it comes to treatment.
Yeah, it's so funny. I have a group of girlfriends who, when I first told them what I did years ago, they said, "You have enough patients to kind of keep you in business, right? Just doing fibroids and endometriosis and those sorts of things." And now that we're all in our 40s, now they all say, "Oh, I can't believe you aren't busier." Yes, I'm booked out for 6 months because there's so many patients who have abnormal bleeding and problems with their cycles, especially as they get older. But really, it can occur at any age, right? So when you guys start off seeing a patient and they come in and they say, "I was bleeding a week out of the month. Now I'm bleeding 12 days out of the month and it's really, really heavy." What's the first thing you guys really sort of talk about? How are you guys going to start working that patient up?
Well, I guess just going back a little bit to what Matthew said, a little earlier, he said that people normalize things, right? So that's, I think, a key component of how we carry this conversation, because what might be normal for someone is not for a lot of people, right? And women are great at normalizing things. If men were responsible for reproduction, we'd be extinct a million years ago, because no guys would be able to put up with this, right? So when someone's concerned about bleeding, I think that the first thing I think about is there any chronicity to it? Are there acute symptoms? Are there ongoing symptoms that may lead to more serious disease like chronic anemia? So I want to know what the frequency of bleeding is. I want to know the volume of bleeding, and that's difficult to quantify. That's difficult to measure. So starting with a blood count is often helpful to see where we're at from that point on.
Yeah, and I think, I think those are great points. I think the whole normalizing symptoms, we see patients every day that normalize symptoms that are just not normal, and for years. And so I think it is helpful from our side to ask questions that are very specific and not kind of like, "Oh, are your periods okay?" And they say, "Yeah, I guess so." "Okay, great." And then send them out the door. I'm very, "Okay, how often do you have your period? How many days does your period last? How many days are you bleeding? How many days are heavy? On your heavy days, how often are you changing that pad? Do you soak through your clothing? Do you have to stay home on those days?" And those are very specific questions that some of these things are not normal. You should not have to stay home every month because of your period. But for some people, they think that's normal. And so they might say, "Yeah, my period's fine. It's been the same like this for years and years." And so that kind of history taking, I think, when we teach our residents, I think we try to make sure, those are the kind of questions that I want to ask, to just see what is actually normal to them. And, we've all had the patients who've come in and said, "Yeah, my periods are kind of heavy." And then you get their blood count and they're like, their hemoglobin is like, "How are you walking around like this?" And they're living like that, So I think being really, a little bit more detailed and not just saying, okay, great, your periods are normal by by the way you feel it is really important, I think, on our side to really address that, because so many of the patients that we see come in and for years they've been told that everything's okay, but clearly not, when you see their pathology.
Yeah, and to the point about labs too, sometimes it doesn't show up as really bad anemia even. They might have slightly low hemoglobin, which is our measure of how we carry oxygen around in our red blood cells. But you look at their iron stores and they show that somebody's been suffering for a long time. And sometimes that manifests with something subtle like fatigue or getting tired at things that they shouldn't be getting as quickly tired at if they weren't having such heavy bleeding associated with it.
So we talked a lot about how people normalize bleeding. I think that's 100%. I see that in my patients as well. How about pressure symptoms? How do people normalize what the pressure or the pain or the bloating bulk symptoms are of fibroids?
Yeah, often I think it's this steady, continuous worsening of the symptom that, again, gets normalized because it's not something that will happen right away. So frequently we hear about frequency of urination, wanting to go to the bathroom more often. Patients that, or women that come in and say, I cannot make it through a movie, or I cannot go on my runs without having to stop several times to go to the restroom. And often fibroids can be small, but also many times they can get very large. And that volume, that mass can compress on other organs, principally the bladder, the bowel, or even, so big that it leads to bloating, a sensation of growth within the abdomen, and that pressure can lead to discomfort and sometimes pain.
Yeah, how many times have you had a patient say they saw a urologist for their urinary frequency, and what was really happening is they've got, a cantaloupe sitting on their bladder. I've also had plenty of patients tell me, "Oh, I thought I was just gaining weight," or to the point about normalizing too. Folks will sometimes sort of write off, well, I don't mean to be vain about it. And like, you're not being vain. You can see, sort of across the room that, there's something protruding here. It's really okay to be uncomfortable with that. And, I think it's also important, we talked about bleeding and wanting to pick that up early. It doesn't happen often, but I think all of us have been treating fibroids long enough that we've seen the weird things and the things that it can sometimes do that can be sort of dangerous. With the bladder, you can get sort of acute urinary retention where you can't empty the bladder at all. And that needs to go to like urgent care to get a catheter or something like that. Or if it's putting pressure on the tube that carries urine down from the kidney to the bladder, that can damage the kidney over long term. It can put pressure on blood vessels that bring blood back from our legs to the heart, and that can make it more likely that somebody will get a blood clot in the legs or lungs. So, these things don't happen often, but they certainly can happen with large fibroids. And again, goes to the point of, talk to your doctor. If something seems like it's not right, volunteer that information, have them check it out.
Yeah.
So many times I hear patients come in and tell me some of these symptoms. And, because we're all consultants, because we're often a second or third or fourth or fifth opinion for our patients, we hear so often, I've told 3 different doctors about it and no one wanted to check, or no one told me that I had this. How did this, did this just happen? Did this just come up? So what would you tell our patients that are listening to be asking for their doctors? What sort of workup do they need if they're in a doctor's office and they feel like they're not being heard?
You have to be an advocate for yourself, right? You know your body better than anybody else, regardless of how many degrees we hold, how many years of training. You're knowledgeable about your body and how you're feeling. So if there's something that appears not to be right, you got to keep going. You got to keep looking for, asking questions. For example, did you feel anything during my pelvic exam, or is there anything else that we can do to make sure that there isn't something abnormal going on? Because although cramping and bleeding and pressure may be perceived as normal or as part of, your cycle, it's not normal if it persists, if it worsens, if it doesn't resolve within a period of time. So continue to ask. There are plenty of people that are unaware of these things, and seeking the specialist's opinion, I think, is the best thing to do. although a lot of people, a lot of practitioners, a lot of providers don't care specifically for fibroids or for women that have problems with fibroids. Most gynecologists will, and especially gynecologists that have an interest in complex gynecologic disorders such as fibroids.
Yeah, and I think it's important to know that there are other things that can cause these symptoms. So it may not be fibroids, but there certainly are baseline, diagnostic tools that we are going to do. We're going to do an exam. We're probably going to make sure there's an up-to-date pap smear or, cervical cancer screening's been done. Some imaging, like an ultrasound. If someone has risk factors for endometrial cause of their bleeding, or we're worried about a cancer, we might do a biopsy. So there are other things that we are concerned about that could be causes of these symptoms. So, when patients are having symptoms, there are some really easy things to do, like an exam, like an ultrasound, that will kind of lead us down the path to see, is this something that's related to fibroids? And that being said, sometimes patients will find fibroids on their imaging incidentally, and they're not having any symptoms. And that's a whole nother, thing of what do we do about that, which we could talk about for a while. But yes, these things need infection of STD screening. I mean, there's many things that we need to do. So we don't, I definitely don't want people to think that when you have these symptoms, you definitely have fibroids, and that's the only reason. There's a whole other host of reasons people can have these symptoms. And part of what your physician or provider is going to do is to be able to evaluate that. But I totally agree with Jamal that if you're feeling uncomfortable, you're feeling like you're not really being heard, it may be that you need to seek another opinion, or maybe specialty care, because there are many, many fine providers out there, but maybe this isn't in their wheelhouse. Maybe this isn't something they see a lot of. And so, you may want to try to be seen somewhere else. And that's fine. Good physicians really, and providers, are not insulted by that. I have absolutely no problems. If my patients want to seek second opinions, I am all for it. I'm absolutely encourage them to do it, and I want them to do that. So absolutely, kind of who I usually be with.
Matthew, you have anything to add?
Well, I would certainly second that thought about, the second opinion. And sometimes even smart folks, you don't pick up on everything. And sometimes it takes, having a little clue here and a little clue there, and you put the story together, and then, you sort of got a working diagnosis. And, I think it's important. You're going to talk about treatment later on, but as you start to think about these things, it's all about individualized care, right? And so it's not one size fits all when we think about working these things up and talking about potential treatments. And if you see a couple of providers, it might be that, one suggestion clicks a little bit more with you than another. And that's a good thing. And, to Arleen's point, I think we all welcome that.
Yeah.
What I'm really hearing from all of you is, for our patients listening, if you have abnormal bleeding that's abnormal for you, if you're having unusual pressure symptoms that are abnormal for you, advocate for yourself. Go talk to your doctor, have them listen to you. And if you don't feel like you're being heard, go out there and find another physician who really can give the time that's needed to really ensure that these symptoms are being worked up, right? Because uterine fibroids are so common, right? Like how many patients do you think we all see a day with uterine fibroids? It's crazy, right?
I love to use the analogy, or the fact that if I were to ultrasound 100 women over the age of 50, that 75 to 80 of them will have fibroids. But more importantly, half of them don't even know they have fibroids, and they don't need to do anything about it. So extremely common, possibly one of the most common diagnoses out there, benign process for most women. So very common, 75 to 80% incidence.
Hey, Jamal, do you mind if I ask a question as
course.
follow-up? What if a patient then says to you, well, how do you know? We mentioned that these are benign tumors, and they want, to answer the question, well, how do you know it's benign? Especially if they're thinking about not doing about something. You said a lot of patients don't need to have treatment of their fibroids. How do you reassure them?
Yeah, that's a great question. I think for so long now, we try to get to the bottom of it with 100% certainty. But that will never happen because that's impossible to do. But I think we use certain characteristics, certain flags, certain risk factors that may be associated with disease that's more serious to make that presumptive assumption that this is benign disease. For example, we often like to look at the size of the fibroids or the rate of growth of a fibroid or certain characteristics that we may see on imaging studies. I like to get MRIs, magnetic resonance imaging, for my patients that have perhaps larger fibroids or are planning surgical treatment or need the reassurance that this is benign disease so that we can perhaps take a step back and watch and observe and preserve fertility if that's what the patient needs. So multiple factors that fall into that equation to help us determine whether this is a benign process or not. So I'd say a combination of history, of imaging, of perhaps even some blood tests that I know is not the best or the most accurate, but there are certain factors that may lead you to suspect disease that's more concerning rather than fibroids. I don't know if that answers it, Matthew, but
Yeah,
combination.
for sure. And I think it also just speaks to the importance of individualized care, right? If somebody has concerning things that they're telling you that make you a little bit more worried, you might investigate a little bit further. And then, the same thing if they've had, as part of their initial workup, imaging, maybe they've had an ultrasound and everything looks really reassuring there. We know that certain types of cancers that can look like a fibroid are really rare, and it's completely safe to sort of stop there. But if they have sort of warning signs about their history that make you a little bit more worried, then you might want to investigate further with something like an MRI or biopsy.
I think this is always the question. Jamal, when you started us off, you sort of said these are small bits of smooth muscle cell that grow. And my first thing in my head is like, oh my God, that sounds like a tumor, right? And so I think so many of our patients are asking that question, Matthew, of like, but how do you know it's not like a bad tumor, right? Like it is a tumor that grows. So I love this idea of kind of individualized care and talking to each patient, seeing what their symptoms have been, following these fibroids over time, doing additional imaging, maybe even doing biopsies to figure it out, right? And I guess my other question for you guys is like, not every fibroid is created equal, right? Like there's some fibroids that we feel like we have to do nothing about, and other fibroids we have to do a lot about. And how do patients kind of figure that out as they're going through? What do you counsel patients with, Arleen?
Yeah, I think that when we have patients who are symptomatic, I will evaluate them, and I almost always get imaging that I think is going to help. So if I have someone who has, say, fibers that are within the uterine cavity that I think I'll remove vaginally, I might get imaging that's a special ultrasound with fluid in it that tells me where those fibroids are. If I'm going to do myomectomy or maybe refer them for embolization, I may get an MRI, and I use MRI quite frequently for many of my patients for preoperative planning, for counseling, really even for patients even if they decide to delay surgery, just for monitoring, because I want to know what these fibroids are doing, particularly in younger patients that are concerned about their fertility and how we are going to manage these fibroids as they go along. So, I think utilizing this imaging will help me to counsel patients, okay, what is the best strategy? And also, what are their goals? What are their ultimate goals in terms of, their uterus, their fertility? Just because somebody, wants to keep their uterus doesn't necessarily mean they want fertility. There's a lot of different reasons that people, want to utilize medication versus not, those kind of things. So all those things are really important. And I think getting your preoperative and your clinical data is so important to be able to counsel these patients and then sharing that with them. So I like to review the images with them. I like to show them where their fibroids are, and kind of that. I think that's really helpful to visualize, to say, hey, this is where this is why you're having these symptoms. Because it's much better than a report. If you can see, oh, here's my uterus, it's this big, and you've got all these fibroids, or you've got like 50 tiny little fibroids. I mean, that type of uterus is much different than 3 large fibroids. I mean, it just is different, and people have different options based on what their uterine pathology is.
Yeah,
So
how many times have you had a patient look at an MRI with you and say, "Oh my gosh, I had no idea that the fibroids were that large or that voluminous," and they can start to map it. You can look at, okay, here's the level of the belly button, and maybe it's at that same level. And yeah, they can I take a screenshot of that? You know, they're
right.
just so wowed by what's been going on that they haven't really.
It
Yeah.
is really, yeah, it's eye-opening for them. And I think even just, it's I think they really appreciate being able to see that. And I mean, even it's so much better than ultrasound just doesn't do fibroids justice, really. I mean, that's why I use MRI for for so many of my fibroid patients, because it really does tell you so much, I think, in a much clearer way what your options are. But yes, Matthew, you're right. I mean, I think the patients really can be really either like surprised, shocked, just like, oh my gosh, no idea that this looked like this. And MRI reports that they read on their phone, it just does not do it justice sometimes.
That's right. That's right.
I really
Yeah,
wish
and
people would insist on that. That is so impactful, to show that image. A picture's worth 1,000 words. So I think for patients that are listening, that may be one of the questions that you want to ask your provider is, can you share the images with me? Can you go over a couple of the images so I can understand the process better? I think that helps people understand the pathology better, and helps them make a decision that will be more impactful for what they're looking for, whether it's uterine preservation, fertility, or definitive treatment.
yeah, and I think that may be too where it can be helpful to have a subspecialist involved who does this a lot and looks at their own MRIs all the time. Not every provider may be comfortable in that space, and that can be helpful to see a specialist that way. And just to make another point on the differences with ultrasound and MRI, ultrasound is really a helpful tool for the gynecologist in general. It's really easy to access, and you can get a lot of information. But to Arleen's point, it really is tough with fibroids because ultrasound uses sound waves, and fibroids are solid tumors. They're heavy, thick, solid tumors. And so those sound waves don't penetrate very well. And so you don't really get a great picture as fibroids start to get larger of what the entire uterus looks like. And I think, again, all of us can probably point to stories where an ultrasound has said, just a few fibroids, and then you get the MRI and it's a much different story. And that really ends up being helpful in terms of counseling. Do we not do something about these at all? Do we intervene? If so, what does that look like? And if we're talking about surgery, how do we plan for that surgery?
I think it really speaks to the fact, too, Matthew, with what you're saying, if like the patients who are so stressed they might have cancer. I often will tell a patient, you have 15 fibroids. Here, I'll count them for you on the screen. And they're like, no, the ultrasound said I only had 3. Have they all grown? No. You just can't see them on the ultrasound. I love that we're all doctors of the same mindset of like, we have to get the best imaging. We have to show our patients what we see to really, really like understand what's causing these problems that they're experiencing, right?
Yep.
All right. So one of the things I always like to share with patients, and I'd love for you guys to tell me your stories about how you do this too, is I don't necessarily talk about exactly how we do our classification system type 0 to 7, but can you guys talk about some of like the different fibroids in the location of the uterus and how that might impact a patient's symptoms for people to better understand what they're looking at? Jamal, can you start us off?
Yeah. I always carry with me a model. I call her Philomena. She's been with me for 20-something years.
Oh my God.
So that visual is, that
I love it.
visual is super important because it's impactful to know the location of the fibroids and how they can, specifically affect you as an individual. And I subdivide it into inside the cavity of the uterus, or in the middle of the muscle of the uterus, or growing towards the outside. And there are different categories for that, and they make a difference in the symptomatology. For example, the fibroids that are growing inside or within the cavity of the uterus may be much more impactful, even if they're small, compared to a very large fibroid that's growing outside the uterus. And luckily, these are some of the easiest ones to treat. They can be done, from below or through the vagina without any incisions in the abdomen. So it's important to know where they are, how many there are, and what different segments of the uterus do they involve. And there could be a combination of inside the cavity and the muscle, outside, or any of those from inside to out.
Yeah. Can anyone comment just on which of those causes the most problems with fertility? You know, so many of our young patients have fibroids and come to us wanting to try to get pregnant or get referred to us from our fertility doctors. Which of these do you guys tell them are the most worrisome when it comes to getting pregnant?
I think it's hard to. I mean, certainly the fibroids that are within the cavity, the submucosal fibroids, can affect implantation of the pregnancy. But then I would argue that those are the ones that are not easiest, but those are accessible a lot of the times if they're smaller or what have you. But you can also have fibroids that are within the muscle of the uterus, or you can have a really enlarged uterus with many, many fibroids that are going to impact a patient's fertility. Or you may have fibroids that are occluding the tubes because they're in a location that are blocking the tubes. And so, it's hard for me to say certain fibroids are worse for fertility than others. I think it's really a combination of location. But yeah, if you had to have a type of fibroid, if you had to have one, I'd probably say intracavitary 2 centimeter, that you can take out hysteroscopically. But I think they all impact in a different way. But and sometimes it's not clear, and I think that's really challenging for patients and for doctors to know, if I take this fibroid out, will this help my fertility? Because I do get many consults like that where patients have a few fibroids and they've had they're on a fertility journey and they've had difficulty and there's no other reason. And the question is, will this fibroid, taking out this fibroid, help my fertility? And sometimes that's not so clear. And performing surgery on the uterus has risks and implications for pregnancy and may commit them to C-section. And so these are things that we have to think about, that are not always as clear as we want them to be when we're counseling our patients.
Yeah, again, just stay on that theme of individualized care. Isn't that where, you start to have these deeper conversations about what's important to you, this person that's, sitting in front of you right there. We often get that question of, well, I have a medium-sized fibroid. Let's say it's, 7 centimeters in size, and they really don't have much in the way of symptoms, but they're trying to get pregnant and maybe have had trouble or just starting to think about the process, and should I get this removed before I even try? And if it's not affecting the lining of the uterus where the implantation of the pregnancy is going to occur, they may well be able to get pregnant without any problem and not having to do anything about that fibroid. But there might be another person who's worried about, well, what if the fibroid grows, which can definitely happen during pregnancy and can cause pain and other issues. And so, bringing into that visit, that interaction, what that individual person's needs are and her history and how long has she been trying, what her age, all of those things, they all kind of come together into those conversations that are a lot more nuanced than just this is a fibroid, here's the effect on fertility, and here's what we need to do. It's not that simple.
Yeah, I think it's so important to differentiate the issues, right? For example, we talk about fertility problems, we talk about obstetrical problems, and fibroids can pose, a problem on both sides of the equation. I think the majority of us would agree that a lot of women with fibroids will get pregnant and deliver without any problems at all. So it's certainly possible to be fertile, to be able to carry the pregnancy, to be able to deliver through a spontaneous normal vaginal delivery, even with fibroids. For the women that have been trying to conceive and have not been able to, and a fibroid is encountered, then there's a discussion as to whether treatment of the fibroid, whether it's removal, radiofrequency ablation, or whatever the treatment might be, whether that's going to improve fertility outcomes. And a lot of people would argue that it would not. But a lot of people would argue on the other side that it may improve your fertility outcomes, specifically for women that are looking for IVF treatment, in vitro fertilization, or assisted reproductive technology, right? So there's a lot of investment there, emotional, physical, financial, you name it. So the thought process is that that fibroids may be inflammatory in nature, and it may be more difficult to implant an embryo if there's a significant inflammatory burden in the uterus, right? So for this specific group of patients, there may be some benefit in considering fibroid treatment if unable to successfully conceive. And then the issue of obstetrical complications that may take place with or without treatment. With treatment, for example, intrauterine adhesions that may lead to placental implantation abnormalities, or the need for a C-section for delivery instead of. And we could do a 10-hour podcast on fertility and fibroids.
And we could even debate it, right, Jamal?
Right. That's right.
Oh gosh, yes.
Yeah, and that conversation might look different for a 32-year-old versus, say, a 43-year-old who's been going through IVF and hasn't had success and has one remaining embryo. You know, the threshold for intervention might be different based on those kinds of circumstances.
Thank you for listening today. We hope you enjoyed this podcast. To listen to other podcast sessions, visit us at gynawareness.com. You can also follow or subscribe to the Gynawareness podcast on Spotify or Apple Music.